Our research found safeguarding was not responding effectively to homelessness and self-neglect. Despite examples of coordinated support, more commonly we found inaction. Staff said making safeguarding alerts feels like just going through the motions, covering our backs. So, what attitudes, practices, and structures were contributing to this? Some safeguarding staff were unclear if homelessness fits under safeguarding or adult social care, or if self neglect needs safeguarding. We found some assumptions about lifestyle choices, dismissing people using drink or drugs. Staff may refuse to do assessments on the street or not understand why people reject support, even when at risk of dying. Often, safeguarding didn't proceed because people were presumed to have capacity to make unwise decisions without a documented assessment. Safeguarding alerts were made by frustrated staff wanting more support for individuals, but finding it inaccessible. Their alerts can then frustrate safeguarding staff who say, "What can we do? There's no service for that." Sometimes services were trying to hand off, not share risks, so safeguarding alerts were used to address stalemates. All these can contribute to a cycle. Use of emergency services, repeat safeguarding alerts, demoralised staff, and chronic homelessness and self-neglect. With safeguarding rarely used, we also looked at other risk management forums, finding some lacked leadership, infrastructure, and governance, so struggled despite good intentions. Successful models had services working collaboratively to address system blocks and clear risk management pathways, removing duplication and gaps. Amongst good practice, we found examples of compassionate, tenacious social work to safeguard people, working flexibly within homelessness outreach. This brings legal literacy, reduced crisis, and improved responses. We talked to people experiencing homelessness and self-neglect who had been referred to safeguarding. Although commonly there'd been no action, they said they might reject statutory support because of distrust due to negative experiences and feeling judged. Addiction, shame, despair, and the obstacle course of getting help were all barriers, but when someone took the time to build trust and stuck with them, that helped. And lived experience staff helped them feel understood and offered hope. So, what did the research conclude? In England, the Care Act 2014 guidance says safeguarding is not a substitute for safe and high quality care and support, but safeguarding alerts are being used to highlight gaps. Reluctance to safeguard is also due to lack of expertise and support attitudes and eligibility decisions. Our economic analysis of homelessness cases found in 2 or 3 improved multidisciplinary responses could have reduced deaths and costs across the system to be reinvested in earlier support and improved lives.